Hello, and thank you for joining us for our presentation. My name's Stuart Tuckwood. I was a volunteer with Cambridge Global Health Partnerships for the duration of this project that I'm going to tell you about. I was previously a rapid response nurse at Addenbrooke's Hospital in Cambridge, and currently I'm the National Officer for Nursing at the Union Unison. I took part in this project together with a colleague who is Olivia Rees, who is also a volunteer with Cambridge Global Health Partnerships, and she's a neurointensive care nurse working at Cambridge University Hospitals. So this is part of the World Health Tract of the conference, and our project is about quality improvement in a resource-limited intensive care unit. We took part in this project at Yangon General Hospital in Myanmar, which you can see in the picture on that slide there, which I'm going to tell you a little bit more about in just a few moments. This project was part of a wider partnership called the Cambridge Yangon Trauma Intervention Partnership. This began in 2017 and is run by Cambridge Global Health Partnerships and funded by the Tropical Health Education Trust. The aims of this partnership are to improve the management of trauma patients across the whole inpatient pathway by embedding sustainable change throughout, with a particular emphasis on medical education throughout, and it involves many different specialities. This project was obviously run as part of the nursing partnership, but we also have partnerships around physiotherapy, orthopedics, pathology, and intensive care. So this project I'm going to tell you about was very much to do with international nursing collaboration between the different arms of this project. Myself and Livy went across as two nurse volunteers from Cambridge University Hospitals to take part in a 6-month placement in Yangon General Hospital in their intensive care unit. There were many different aspects to the work that we did while we were in Yangon General. We did a lot of teaching and education. You can see in this photo here one of the sessions that we taught local nurses on the management of spinal cord injury patients as an example. We also took part in a lot of research and collected a lot of data from the intensive care unit in Yangon General. The project that I'm going to tell you more about was around quality improvement and improving infection control practices. And we also ran programs of life support training while we were in Yangon and trained many different nurses and nursing students in basic life support. For a little bit of background, this is Yangon General Hospital. You can see in the photo on the right. It's the major public hospital in the largest city in Myanmar. That golden pagoda that you can see there in that other photo is the Shwedagon Pagoda in Myanmar, in Yangon. The intensive care unit is a 20-bedded ICU which manages trauma and various other conditions as well. There are patient-to-nurse ratios of around 4 or 5 patients to 1 nurse in that intensive care unit, which is obviously quite different to the context in which we worked in the United Kingdom. And it was a mixed public-private treatment model in the intensive care unit. So some of the treatments were public, but for some more advanced treatments like dialysis or certain drugs, patients had to pay privately. So the project that I'm going to tell you about was around quality improvement, and we worked with the local nursing teams in the intensive care unit to implement a collaborative care bundle which aimed to improve the practices of the nurses and the clinicians in the intensive care unit, with the aim of reducing the incidence of line-associated infections in the intensive care unit. You can see broadly some of our aims there. The context was that the routine microbiology and the testing in the intensive care unit was not really in place, so it was very difficult to establish a baseline of how many line-associated infections there were. But through conducting audits of local practice and working with the local nurses, we identified this as being an issue and an area that they would like to improve their practice in. We followed a PDSA model in terms of the implementation of this care bundle. So we planned, we did the interventions, we studied the results, and we acted to try and resolve and overcome the barriers that we identified. And we followed 2 cycles of that model in the implementation of our project. So I'm going to tell you a little bit about how we implemented it, how we generated the idea, how we reflected on what needed to be changed, and our final outcomes, and then a little bit at the end about the conclusions that we came to from taking part in this project. This is our implementation timeline. So around November 2018, we came up with the idea for implementing this care bundle through discussions and teaching with senior staff from the nursing team in the ICU. We carried out training sessions for the intensive care nurses and designed the care bundle together. We actually designed different options for the documentation that the nurses would use when assessing the lines that their patients had in the intensive care unit. And we allowed the nurses and the nursing students on the intensive care to vote on their preferred options of documentation to really ensure that they were involved and engaged in that decision. We trained 27 nurses, doctors and students one-to-one at the bedside in how to perform the care bundle and how to use the documentation that they'd selected. Towards the end of December 2018, we also displayed posters around the intensive care unit explaining the rationale and how to conduct the care bundle. And in January 2019, we, together with the local nurses, carried out the first audits to check on how practice had changed after the implementation of the care bundle. Here's some examples of how we went about doing that. So these are just some pictures of work that we did together with the local nurses in our education sessions. We were doing a lot of teaching around the chain of infection and how to break that to try and improve infection control practices. And as you can see in the picture on the right, we, by working together in these sessions, managed to design an evidence-based care bundle that the nurses on the intensive care unit would be comfortable in implementing. Here are some pictures of that work. So on the left, this is the nurses reviewing the different options for documentation, and on the right, voting on their preferred option. Here's some examples of the materials that we used. On the left, we have an educational poster that we displayed around the intensive care unit, which explained the aims of the project, why we wanted to do it, and the 5 different domains for implementing the care bundle. These 5 domains that we implemented were to see hand hygiene being done prior to accessing any line, to see that the nurses and clinicians used a new pair of gloves before accessing any line, to see, thirdly, that they decontaminated the line with an alcohol swab before accessing it, then that they exercised hand hygiene again after accessing the line, and fifth, that they daily documented the location of the line and checked that line for any sign of infection as well. And they would document that in this documentation that we have on the right here that was chosen by the local nurses. And this documentation would also prompt them to review how long the lines had been in place, which wasn't something that was done routinely before, to try and ensure that lines were taken out before obviously they became infected. And here's a good example in a picture of the way that the nurses adapted to the care bundle to change their practice and improve their infection control practices. So previously, prior to using the care bundle, many of the nurses would do all the IVs at the same time without necessarily washing hands or assessing the lines while doing so. They began to use this trolley, as you can see in the picture, to take around while doing and carrying out IV medications or hanging IV fluids. As you can see, they used alcohol gel on the trolley to make sure they could decontaminate their hands before and after accessing the lines. And they also carried around blank sheets of the care bundle documentation, which they could use to put in the patient's notes as needed to make sure they were keeping up with the documentation. And here are some of the outcomes that we saw after the initial audit of the first cycle of the project. So we saw big improvements in 4 of the 5 domains of the care bundle. Their hand hygiene prior to accessing the line went up by 43%. Their use of a single pair of gloves went up by 33%. Hand hygiene after accessing the line went up by just under 29%. And around half the time, they were assessing and documenting the lines routinely, daily in the patient's notes. However, we did see a deterioration in practice around the decontamination of the line with alcohol swabs, which was obviously worrying and was something that I'll talk more about in just a minute. We worked together with the local nurses to review the results. So we went through the results of each domain together with them in one of our teaching sessions. And together we came up with some goals for the second phase of the project, which was really a good way of engaging them in the process and helping them become really motivated to try and improve their practice. And we agreed some quite ambitious goals for the second phase, and we'll find out in a few minutes whether we were able to achieve those. Some of the challenges that we identified in terms of the implementation of this project, which are good challenges to reflect upon when carrying out any kind of project of this sort. The first was that through discussions with the local nurses, we realized that they were finding it very difficult to locate and complete the documentation for where the lines were in their patients. And the nurses in the intensive care unit often had to spend a lot of time looking through the patient's notes at the end of their beds, which included many different notes and investigations. And actually that was really difficult for them considering the time pressure that they worked under. So we overcame that challenge by introducing dedicated nursing documentation folders, which contained only a few really important items of documentation, which really made it a lot easier considering the time pressure for the nurses to complete that assessment. We also found it very difficult to reach many of the nurses and the clinicians that were working on different shift patterns. For example, many of the nurses who worked night shifts. So we found a lot of variation between different shifts of nurses in terms of their practice and how well they'd done at implementing the care bundle. We thought quite creatively about how to overcome this, and we realized that training some of the local nurses and doctors to actually be infection control champions themselves and to train their colleagues was a really effective, good way of doing that, and also ensuring the sustainability of the care bundle. And we did that as part of the second cycle of our project. We also reflected on why the performance of the nurses and the clinicians had got worse in terms of decontaminating the lines before they used them. And we realized that there was a real problem in the translation. And when we thought the nurses had understood what we were talking about, actually there'd been quite a lot of misunderstanding. So we overcame that by shooting a Burmese language video showing the correct use of the care bundle and the documentation, where one of the local nurses used me as a model to demonstrate how to use the care bundle while narrating what she did. And that meant that we were able to communicate the different aspects of the care bundle much more clearly to the local nursing team. So this slide shows the implementation of the second phase of our project. So you can see that we started this around mid-February 2019. We carried out another teaching and development session aimed at planning this second stage. We also, around mid-February 2019, introduced the dedicated nursing documentation folders on the intensive care unit for the nurses to use. We shot the Burmese language video and disseminated that to the rest of the team working there towards the end of February. And in March, we carried out the training of 5 additional infection control champions who were doctors and nurses working on the intensive care unit so that they could train and support their colleagues. And getting into March 2019, we carried out the final 3-day audit of the care bundle to see how much the domains had improved. And here are some pictures and additional slides just illustrating how we overcame those challenges together. This is one of the local Burmese intensive care nurses showing off the dedicated nursing documentation folder, which contained the care bundle documentation and vital signs flow sheets to enable them to access the documentation much more easily. Here's myself as a model and another of the local nurses narrating in Burmese and demonstrating the optimum use of the care bundle, which we were able to give around to the rest of the nurses. And here is one of the senior intensive care nurses working in the intensive care unit who we were able to train up as an infection control champion. And we also produced badges which we were to give to these clinicians to show that they were the ones that were able to train colleagues in use of the care bundle and conducting audits. So did we achieve the goals? I'll show now the results of the second phase of our project. So in terms of hand hygiene prior to accessing line, we'd set a goal of 60% at the end of the second phase. And actually the local clinicians achieved 67%, which was obviously above our expectation. In terms of using gloves, single-use gloves for accessing lines, we'd set a goal of 70% by the end of the project, and actually it was 90% that they achieved, which again was better than our expectation. The line decontamination, as I said, that practice had deteriorated in phase 1, so we were very pleased in phase 2 to see that the practice improved from 8% of the time to them decontaminating lines with alcohol 76% of the time in the second phase, which was obviously a massive improvement. And in terms of hand hygiene after accessing the lines, we went from 37% at the end of phase 1 to 76% at the end of phase 2, which is again an excellent result. And the nurses hadn't previously had any documentation about the location or any signs of infection of their lines in their patients, but by the end of phase 2 they were completing that documentation on a daily basis fully 92% of the time, which was a tremendous achievement for them. So some of our conclusions, obviously we had some measurable outcomes and some outcomes that we couldn't measure. We saw a big improvement in the infection control practices that were part of the care bundle in all the different domains, and the nurses and the local clinicians achieved all of the aims that they set at the start of phase 2. And as I've already said, the documentation of the lines was near 100%, which was fantastic. We saw a lot less variation across the different days of the audit, which suggests that the nurses had a much better understanding of what they were doing and why they were doing it. And some of the things that weren't measurable, obviously we couldn't actually measure the incidence of line-associated infections because the intensive care unit, with their microbiology being quite limited, weren't set up to be able to do that. But hopefully we would have hoped to see a reduction in the incidence of line-associated infections. What else was really good to see was that just how engaged and enthusiastic the nurses were about taking part in this project. We saw many examples of the nurses on the intensive care unit training up their colleagues and showing off the care bundle that they did to nurses that came to visit the ICU, which was good to see. And by the end of the project, there was a lot more peer support and peer pressure to achieve higher standards, which was very good to see. In terms of just considering some of the implications of coronavirus, obviously it's much more difficult for us to maintain partnerships like this overseas and continue exchanging practice when travel restrictions are in place, so that it's a challenge to maintaining the sustainability of projects like these. But projects like this do also show ways that even in resource limited environments like an intensive care unit in Myanmar, that infection prevention and control measures can be improved, which will help to prevent the spread of certain infections when things are done collaboratively and where local nurses are really engaged and really take part with enthusiasm in projects like these. So thank you very much for listening. I hope you found this really interesting. There's much more information published online about our project, and we'd be very happy to take emails or any questions about this project afterwards. Thank you for listening.